Good morning, it's Dr. Bone.
And I'm Dr. Tartaglia. We're here today to talk about deprescribing.
Deprescribing is when patients and physicians review their medications to try to determine, are we taking more than we should? Are we taking enough?
It's a good habit to review all the meds as it encourages physicians to complete a medication reconciliation at visits. You should be doing this for all patients that are on 5 or more medications. However, especially in the geriatric or palliative population.
Any frail patient that's on a lot of medications, those medications could get to where they're interacting with each other. They might have been tolerated at one point in time and they're no longer being well tolerated. Maybe the patient doesn't need so much medication anymore. Possibly the patient needs more medications. And we're not just talking about medications to treat an illness, but we're also talking about supplements and vitamins, stool softeners. All of those count.
Yeah. It ensures that we are using the medication safely and effectively.
Mm-hmm. It provides an opportunity for the patient and the family to review all those medications with their physician.
Mm-hmm. I think it also promotes a better, improved communication between the patient and the family, and the healthcare team creates a collaboration.
Because paternalistic practice really has changed to collaborative practice. We want to involve the patient in their own care. We want to educate them about their medications, about their illnesses, so that they can make those important decisions about what's important to them.
Mm-hmm. The thing that you have to realize is deprescribing takes a lot of time, and you have to have a lot of knowledge and skill set. For physicians, we are on a time crunch with our patients, but it's very important for us to maybe review the medications before we go into the patient's room, already try to come up with a plan of action of side effects and what could be causing harm to the patient.
Depending on what the setting is, it's really nice in an office setting if the nurse or the intake personnel will get that list corrected. So we always encourage patients to either bring an accurate list, or in some cases, when I was in private practice, I always asked patients to please just put all of their medication bottles and bring them in, I used to say a Walmart bag, but just bring them all in at one, container, so that we can go through each of those. I also would encourage patients to, bring me a list of the things that you want to talk about today. And I know sometimes patients would bring in a really lengthy list, and they might have quite a few medications, and I would look at the list and I might pick out 2 or 3 things I think out of their list are important. And then I would tell them, you pick out 2 or 3 things. We'll get through the most important ones first for you and for me, and then we can go further if we need to.
Right. And the goal of the medication reconciliation is to reduce the overall burden, and that's what Dr. Bone's talking about. A lot of times, people that are on lots of medications, they're just, it affects their appetite, it affects their activities of daily living, because it's a big burden every morning to be taking out those medications, trying to figure out what to take. Sometimes they get mixed up in different pill boxes, and there's a lot of side effects that can occur if we're not taking the medications at the right time of day.
Some patients will set up a pill planner, and it might have a morning, noon, afternoon, evening time frame for those medications to be taken. And if they're on multiple medications, it's easier if they have a pill planner, because they have those medications already set up for the week. And sometimes medications are multiple times a day, and sometimes they're only once or twice a week. And that's really important for that to be done accurately.
Yeah, and I think with the pill planner, it's really important to have a calendar near the patient, because a lot of times if there's cognitive impairment, that can get confusing on what day of the week it is. So it's really important to just have that 1 week out for the patient, right. And then maybe have a calendar there so they can check off, okay, I've done Tuesday, this is Tuesday on the week.
And a pill planner is also nice, because once it's set up for the week, and maybe they've got a family member or a neighbor, or maybe they've got a home health or a hospice nurse that's coming in and helping them set that pill planner up, the accuracy can be checked in the pill planner. And then when you know that little cup for that little portion of the day is empty, you know that you took those meds. I know it happens even for me sometimes. I'll think, did I take my medicine this morning? And the only way I know, rather than going back to the bottle, is I put mine in a pill planner, because I'm trying to remember, the days do begin to run together. And if somebody's got a little bit of, cognitive impairment, or if they're a very busy person trying to take care of another loved one, or they've got things happening in the home, they can forget if they took that medication or not. So it's handy to have that.
Right. And when we're doing medication reconciliation and withdrawing medication, i.e. deprescribing, we do it on an individual basis. We look at patients, like for example, if patients are falling, okay, we will review the med list and make sure that we're removing anything that may be causing falling, or just try to talk to the patient, when are you taking that medication that may be promoting falling? And we try to take that medication away. For some patients with dementia, we really have to be careful of the burden of medications. There's, like we were saying, if they don't have a pill box, we need to have them get a pill box. Have someone without dementia pouring out the pills to make sure that they're poured out accurately.
Right. And
try to reduce the most amount of medications that we can safely, so they do not have a pill burden. And it will be less complicated for them, and then they can still feel in control of their health care.
And that's where it's really important to talk with the patient, the family, the caregiver, how the patient behaves, acts, feels at different times of the day. Is it interrupting sleep? Are they taking a medication that makes them drowsy? Are they taking a medication that upsets their stomach? Are they not getting a medication and they need something for upset stomach, or they need something for their bowels? So medications, even though sometimes you get a pill from a physician and say, you'll have to take this forever, that's not exactly true. It's dynamic, and we need to be reviewing those medications on an ongoing basis to look at, are we still getting good benefit from these medications?
Yeah, and I think that patients think that that's true, that they have to take them forever because they were prescribed by a physician. However, we're trying to promote collaboration and remove the paternalistic instinct of being a physician superior to the patient. We want to have a collaborative relationship where we're equal.
I used to explain it to patients that the previous model, where there was paternalistic, is me, doctor, you patient. I'm not going to tell you what it is. You don't need to know what it is. I'm going to tell you how to take it. You take it the way I tell you to take it. And so patients, there was a lot of mystery, and patients didn't have a lot of control. And we really believe that patients need to take control of their health, and physicians need to take back control of healthcare. Healthcare's gotten to be big business, and we need that patient-physician relationship to be in the forefront.
Yeah, and if you educate your patients on what their medications are doing and why you need to take them, then they're more apt to take them if they understand why they need the medications.
They have that buy-in. And then they can make a decision as to, I am getting good from this medication, I know what it's for, and I might get a little side effect, but I understand the risk and the benefit associated with this medication, and at this point, from a patient standpoint, I feel like it's still a good medicine for me to be taking. Or they can tell you, I'm taking so many medications, I don't even want to eat right now because I'm full of pills. That's important information for us to have.
Exactly. One of the main things we do when we're looking at reducing medications is we try to look at the ones that could potentially cause harm to the patient.
Fall is a big harm to a patient.
Yeah. Falls, even if they don't cause a major injury, they may cause a setback in your activities of daily living, being able to care for yourself, which may cause you to weaken and further weaken in your chronic illness. A lot of medications that cause falls in the elderly population are like benzodiazepines. They're medications that are used for anxiety. Antipsychotic medications are medications that are used for behavioral disturbances with dementia patients. Antidepressants, a lot of patients take antidepressants. We're under a lot of stress in our world today, so a lot of people are taking SSRIs, which is the newest form of antidepressants, and there's other medications that are sedatives that we use for sleeping.
So each medication has its definite benefits depending on what the patient's symptoms are that we're trying to manage, but they also have potential side effects. And so that information is intricate, and we need to tease that out during our evaluation with that patient. If their anxiety or their restlessness or their sense of shortness of breath is so debilitating that their quality of life is limited, then a benzodiazepine may be warranted. And there are some benzodiazepines that are safer than others. Some have a very short duration of action, but they have a high quick peak. So that risk of fall is for a short period of time because of that high quick peak. And so when they have that high quick peak, it may cause other effects where you have that need, that urge for that medication. Where others maybe have a longer, slower peak, but it may last maybe, 8 hours or 12 hours. And so depending on what the desired effect and the risk of fall and side effect are, that's what helps guide that physician as to which one of those is going to be the most appropriate for them. The same thing with the antipsychotics. There are multiple antipsychotics, and what is appropriate now may not be the same medication that was needed a year or 2 years ago, and it may not be the same medication or dose that's needed in a year or two from now, because patients' journey through their health care is not static. Things change, and so we may need to change those medications to help manage those symptoms so the patient feels more functional.
Right. And even with antidepressants, oftentimes you're put on it for an acute event that may have resolved. Like say you had a death of your spouse. You may be put on a certain antidepressant. There's a lot of antidepressants that have they're used for multiple things, for multiple mechanisms of action. So for example, there are some antidepressants that help stimulate appetite, increase energy. So these kind of would be given more to the frail patient that is losing weight, not awake most of the day. Though that would be a type of medication that you would utilize, not something that would be more of a downer. That would cause them to lose more weight, because that is also some of the SSRI. So you have to look at the patient and treat them as an individual.
We want to try to match side effects, because every medication has a side effect, with some of the other symptoms that the patient may be having. So certainly if you've got a patient who comes in and they have depression, for instance, and you're thinking, oh my gosh, there's so many medications to choose from. Well, is this an anxious, depressed person? I can't sleep, I can't rest. They're drumming their fingers, they're bouncing their leg, I can't focus on things. So there may be a hypervigilant type of depressed person. Or you've got somebody that's maybe motor retarded. I don't have any energy. I can't get up out of bed. I can't manage to do, the things I know I want to brush my teeth, I want to comb my hair, I need to do my laundry, and I can't hardly, get up to get my own breakfast because I'm just so lack of interest in things. I don't have the energy I need. So maybe we want something that's going to be more uplifting. Maybe the person's depression is affecting their appetite. Maybe it's affecting their sleep-wake cycle. So we try to match potential side effects with the antidepressant that has some of those side effects.
Yeah, and it's important when we're deprescribing to look at how to improve and preserve your cognitive function, because again, falls is part of your ADL care, meaning part of your functional status, and then to preserve the cognitive function, you're able to think clearer, and this also preserves your illness progression with and your ability to do things on your own. So it's really important for us to again look at the same type of class of medications, so I won't bother repeating it all, but look at how they can improve your overall function.
Because we want the patient to remain as active and as functional, as healthy as we possibly can, and we're all about aging in place. We want the patient to be able to remain in their home, whatever that home setting is, because when patients can no longer remain in their home, that implies that we have had a decline to reach a certain point, and then when a move occurs, we know there's going to be a sudden downturn to find a new plateau, to find a new baseline. And so we really don't want to move those patients any sooner than we absolutely have to. And that's why monitoring these medications is so very important and crucial.
Yeah, and it does reduce the risk of hospitalizations in the vulnerable population. It also reduces the risk of death. So it's
by about a third in each one.
Yeah, so it's significant. So it's really important. When we ask, who should we focus on deprescribing? Well, obviously patients that are in polypharmacy. Now, by definition, it says 5 medications, but everybody these days are on 5 medications.
And I think in the nursing home, I think it's 9, but they're counting on stool softeners and vitamins. But if you've got somebody that's got several medical illnesses,
yes,
I mean, if they've got a lung problem, they may be on inhalers. If they've got a sugar problem, they may need a medication for diabetes. If they've got hypertension, they may need 1 or 2 antihypertensives, and that's just for their chronic illnesses without
Right.
looking at anything. It's easy to get to 5 or 9 medications pretty quickly.
Yeah. And like patients, like Dr. Bone just said, they have multiple comorbidities. So how is their kidneys functioning? Because a lot of our medications are metabolized through the kidneys. And if you already have renal impairment, their metabolism is going to be different from each patient, from patient to patient. The big thing that you need to look at is most patients have multiple prescribers these days. The hospitalizations have changed. There's no longer the family doc going into the hospital at the end of their night after finishing seeing patients 6, 7 o'clock at night to round at the hospital, or going there at lunch to grab lunch and go see your patients. Now there's hospitalists that are seeing your patients. The hospitalist team does not know the patient from the home setting. The patient that's coming in is sick, so they are not able to sometimes give the proper medication list. So there's a lot of medications that can be added during a hospitalization, which can create complications when you go home.
Many patients don't carry a list with them. So if something were to happen, maybe you went to a relative's home, maybe you had a flat tire and you got overheated, but for some reason you wind up in the hospital and it's unplanned, typically it is unplanned, you don't have that accurate list, so nobody's really sure. So there's problem number one. And another problem or issue is you may be on one brand of medication or one type of sugar medicine or blood pressure medication or medication for acid reflux, and you get to the hospital and they say that's not on our formulary. And what that means is we're going to give you something similar, but it's not what you've been taking. So then when you go home, that hospitalist gave you a bunch of prescriptions and sent them to your pharmacy, and you were taking a medication for your blood pressure at home that you still have maybe half a bottle or maybe a full bottle left, and they sent you home with one that was similar but not the same. You get home and you're looking at those names and you're like, do I take both of these? I mean, what do I do with these? They sent me, I had 5 meds at home, and I came home with 5 meds, but none of them have the same name. Are they the same medications? Did I go from 5 meds to now I'm taking 10, or are some of these duplicated? So it's really important to bring those bottles in, to have that list of those medications, and put a list in in your wallet, on your phone, in your purse, so that you've got that list with you.
Right, and it's really important to capture the transitional care visits, but honestly, sometimes that doesn't happen in 72 hours or 48 hours from the discharge. That's ideally what we'd like, but if the patient's discharged over the weekend, they might not call their primary care till Monday, it may not be seen till Thursday, so it's really, really important to be proactive, have your list in your pocket, in your purse, in your wallet, because that will really help you, God forbid, if you have to go to the hospital.
Another topic I want to bring up is medication non-adherence, what that means, and coupled with that is something called enforced compliance. Would you talk about non-adherence for a moment?
Well, medication non-adherence is when a patient does not follow, is not taking the prescription as prescribed. So basically, it can be for several reasons. Most of the time, it's because it could be cost prohibitive. I mean, a lot of times we forget our patients are on a fixed income. They have multiple illnesses. They're unable to work. Medications are expensive. So it's really important to review that with the patient, costs, and then make sure that they're going to be able to fill it. Other times, it could be side effects that they decide to not adhere to medication. And sometimes it's just they don't understand the importance of taking the medication. So
non-adherence and compliance with those medications is really important for us to know. And it's not my medicine. It's not like I baked you a pie and you didn't like it and now I got my feelings hurt. It's a relationship you need to have that's open with your physician, so they know you don't like that medicine or it's causing a side effect.
Right.
Now, enforced compliance is where a patient is either at the hospital or at home, but they're taking those medications, and then they get to a place where they're not taking them as they're prescribed, and then they have to go to another care level. So they go from home to a nursing home to a hospital, and we see what's written on the bottle or what's written on their list, and we give it that way. We make them take it that way, and we enforce the compliance, and now they start having side effects. So as a sidebar, I was taking care of a little patient, and I can't say she was my patient. I was there in a capacity just as a medical director for a hospice agency, and I was doing a recertification exam. And so while I'm sitting visiting with her, the nurse comes in with a little cup of pills and hands her that cup. She dumps it in her hand. She takes the pills. The nurse hands her the cup of water, and she drinks the water. When the nurse leaves, the little lady opened her hand, and all of those pills are still in her palm. Now, she's got her little walker in front of her, and it's got like a little cloth basket hanging on it, and she picks out the big one, which I was pretty sure was her potassium. She goes, I don't take this one. It's hard to make it go down, and it hurts my stomach. And potassium can upset some people's stomach. So she puts it in her little bag. She picked up another white pill, and this one I was pretty sure was her Lasix, because she goes, this is the water pill, and it makes me wet on myself. I don't take it unless my ankles are swollen. So she put that in her little basket. She picked up another one, and I can only guess that was a multivitamin, because she said, this one is really big and it gives me bad breath and bad burps. And so she put that one in her basket. She said this one, and she picked up a real tiny one, and I'm only guessing that's her Dig because of the size of it. She said, I think this one is for my heart, which is probably digoxin. And she goes, if I take it very often, it makes me nauseated. And that's a key tip-off that somebody's toxic on their digoxin, is they can get nauseated. So she put that one in there. And then she said, these others I'll take. They don't seem like they bother me as much. So she took them and finished her cup of water. And then she told me, she said, I have to remember to put those in the toilet, because if they find those in there, they'll know I'm not taking them, and they'll watch me close and make sure I take them, and then they'll make me sick.
Wow.
She knew the side effects. She didn't know the names of her medicine, but she knew what each one of them was supposed to do, or you know, what organ system it was supposed to do, and she knew the side effects. But she felt like, I can't tell them that because they're going to make me take them that way, and that's enforced compliance, and it's not what we should be doing. We need to listen to the patient about how those medications make them feel. With her aging process, this lady was over 90. She's not metabolizing and clearing many of those medications the way she needs to. Her heart doesn't function well. Her kidneys don't function well. She may not need as much medicine as she used to need. So, you know, talking to her about how she's taking them, the side effects, the compliance, and not enforcing that compliance would have alleviated a lot of that. Now, she swore me to secrecy, and I said, I'm just here as the hospice doctor. I'm not the medication police. So I said, I don't know anything.
That's funny. Well, oftentimes we also have to deprescribe when patients have a limited life expectancy. They could be older in age, or they could have advanced frailty or dementia. And I have a story that goes along with that, because as a hospice physician, for most of my career, I came out of my family practice residency, and my very first patient that came to the hospice unit was from one of my dear friends and colleague. And she, you know, called to let me know that this patient was actively in the dying stages and will be coming over to the hospice unit. And it was one of my very first patients. And I kind of drew the small straw for the physicians, because no one else wanted to take care of this demanding family. And I looked like a hero 10 days later, because I had stopped all the medications, because the patient was no longer swallowing. She became very lethargic and weak. So I just stopped all medications and just did comfort meds as needed. And within 7 days, because she had very low renal function, she was 93 years old, she woke up and went back to her baseline. And slowly, you know, we had to put back on her heart pill and her water pill. And then she went on to live 3 years with congestive heart failure on a hospice service. Never went back to the hospital, because, and that was her wish. Her dying wish was never to go back to the hospital, to die at home. And to the family, I look like a hero. But for me, I was just doing, you know,
the deprescribing,
the reviewing of the medication, saying that the patient no longer needed it, and then just adding it in a stepwise approach.
So an elderly patient does not necessarily equate to a frail patient, does not necessarily equate to a demented patient, and is not the same as somebody who's, you know, debilitated or at the end of life. Those are separate, you know, patient populations. Certainly it could be the same patient, but not every frail patient is older. Not every demented patient is frail. So we really need to look at all of those factors. It's a lot to try to to balance. It's a lot for us to try to process, and that's where we need to talk with that patient. We need to spend time with that patient and with that family. And when in a rushed environment, you're not going to be able to get that.
So there's some high-risk medications. We kind of already went over them, but we can just briefly describe to you some of our high-risk medications, like our sedatives. They're the hypnotic medications, and we already kind of went over why we want to get rid of those, because they will make you sleepy, they'll increase falls. They may change behavior in seniors or even in people that have renal impairment, which means decreased kidney function.
Then there's anticholinergic medications, and you might think of those as medications that maybe dry a person's mouth out. You might get dry eyes with it. It might cause constipation, and they might be taking that for dizziness.
Right.
They might be taking some of those for upset stomach, and without realizing it, they're taking it for one thing, and it's causing multiple other side effects. Right. And some disease processes, like Parkinson's, those anticholinergics can actually make those medical conditions worsen while you're taking it. And then when you stop those medications or you decrease them, the illness gets better, and maybe some of those side effects. So you've got, the benefit of the medication, and then you got the side effect of the medication, and that's where the patient has to tell us, it's still doing me good. Yes, I get a side effect. And, years ago in the paternalistic practice, patients would say, I don't like taking that medication because it gives me this side effect. And the doctor would say, good, keep taking it. That's how you know it's working. Well, I just don't know that that's the best thing. It's not what I want you to take. It's what I think is in your best interest that agrees with you.
Chronic NSAIDs like, ibuprofens, Aleve, people take that for pain relief, right? But
arthritis medicines.
Yeah, arthritis medications. But, you have to be careful with those, because what is the patient's kidney function? And then also it causes risk. It could cause a GI bleed and cause more harm that way. So you have to add another medication to counteract the first medication, and causes upset stomach. I mean, there's so many side effects that can be caused just by taking ibuprofen or medications for arthritis on a daily basis or routine basis.
And you may think, well, the arthritis medicine, if I take it on a full stomach with a meal, it's going to keep it from, sitting in one spot, and so I'm not going to have that bleed. Well, it's a prostaglandin inhibitor. And so on the chemical level, if it's inhibiting those prostaglandins, your risk of bleeding is increasing.
Yeah.
So if you're bleeding, it's because it's working. So that it's not necessarily a good thing.
No.
And the more frail a person is, or if they're older, not necessarily the same thing again, then they're at risk for bleed.
Exactly. PPIs, or proton pump inhibitors, they were really big, years ago. We got a lot of merchandise from pharmaceutical companies about starting everybody on PPIs.
There's a lot of commercials for them.
There's still a lot of commercials. A lot of them now are over the counter. So again, you make sure that you're always looking at all medications, like Dr. Bone said earlier in our video. But you have to make sure that, does the patient really need to stay on the PPI? Because now, over the years, there's been a lot of study and research that they can be harmful. So does the patient have a history of Barrett's esophagus? Are they on chronic NSAIDs, which we just discussed, the anti-inflammatory medications, where they would need that to protect their stomach? Do they have a history of bleeding, like an ulcer? Are they on chronic steroids? Like we haven't talked much about the COPD, the chronic obstructive pulmonary disease patients. So are they taking steroids every day where they would need that? And then patients that are on chronic medications for bleeding, the chronic anticoagulation patients.
And maybe they've got atrial fibrillation, or they've had a stroke, or they've got peripheral vascular disease, and the physicians feel like risk-benefit, they really need to be on something to make their blood a little thinner and a little bit more slippery, so it's more likely to be able to get through those places without causing a stroke or a heart attack.
So you imagine, just with that one class of medication, the uses are so vast. There's so many different reasons as to why they would be on them, and there's side effects to those illnesses that play a role with the PPI. And the big thing is a proton pump inhibitor changes the flora of your body, of your GI tract, so it can cause you an increased risk of C. diff, which is a very hard infection to treat. It can cause hip fractures. And because it plays a part in changing your flora, it also impairs the absorption of different vitamins, especially B12.
So you think, I'm taking that for my stomach, it's just a good medication for me, but you don't realize in the background it may be accelerating bone loss and putting you at risk for fractures. It may be causing you to be at risk for a colon infection. There's bacteria in your colon, and there's good and bad bacteria in there all the time, and we don't want to make the bad bacteria outgrow the good. We want to keep them in balance. And then if the medication is causing you to not absorb certain nutrients, then you're going to get a vitamin deficiency.
Yeah.
So yeah, that may be helping something, but it may have risks that you didn't even realize.
Another class of medications is our glucose-lowering medications. These are for mostly diabetic patients, people that have renal impairment, their kidneys are not functioning. They could have a history of also low blood sugar. And multiple chronic conditions, including dementia, can play a role. So basically what we're trying to say is anybody with diabetes, you have to ask them, have you ever had a history of low blood sugar where your blood sugar gets very low and you have symptoms related to that? And make sure that you have them on the proper agents to try to offset chances of hypoglycemia, because as they get more demented, they're not aware that their blood sugar being
As
low.
we age, and we've had diabetes for a while, our body loses that early warning system. And so some people with diabetes will tell you, oh, I woke up in the night, my heart was, kind of beating fast, I was in a sweat, I had this sense of impending doom, and I got up and I checked my blood sugar, and it was low. And so I had to get up and I had to, have some orange juice, or I had to eat, some peanut butter and crackers to get my blood sugar to go back up. As we age, we lose that those early warning symptoms, and we don't realize our blood sugar is going low, and it can put us at immediate risk. So if you're, dusting and you got your arms up over your head, you're changing a light bulb, you're up on a step stool to try to reach something off a top shelf, and your blood sugar drops, you are at immediate risk for fall and for injury. And what we're trying to do is trying to delay that diabetes from causing damage to your eyes and your kidneys. But if we have you with low blood sugar and you fall and you injure yourself right now, we didn't do you any favors trying to stave off something that's going to happen in 5, 10, 20 years by putting you at risk and giving you a fracture right now. General rule of thumb, your blood sugar should not be within 10 of your age. So if your age is 60, certainly you can tolerate a blood sugar down to 70. But if you're 80 years old and we drop your blood sugar less than 90 or down to even 100, you may not realize it. You won't get those symptoms and you could fall.
Yeah, and it's really important to be looking at those medications.
So several different societies have recommended that for an individual who has diabetes and has blood sugar, if they're aging, that we need to let them have a higher blood sugar.
Yes. Yeah, and even the hemoglobin A1C should be more elevated than a younger person.
So they get a little bit more liberal diet.
Yes.
We don't control them quite as tightly. We let them have a little bit more sugar in their system.
Antithrombotic medication, which are medications that are used if you have ever had a blood clot. It could be used for people that have had strokes, they have atrial fibrillation, they have peripheral vascular disease. All these medications can be used to thin out the blood. We have to look at, is the risk outweigh the benefit for these medications? Because if you were to fall with these medications, they may cause severe harm. They may actually, cause you to pass. So we have to look at what's their diet, what's their intake like, look at the whole patient, know what their functional status is before we prescribe these medications. For me, as a palliative physician, these medications drive me insane because a lot of times they're started at a hospital setting and no one assesses their functional status at home.
And so what we need with that collaborative relationship with that patient and the family or the decision maker, if the patient's not able to decide for themselves, is we need to know, is this risk worth this benefit? Because if you've got a frail, demented, elderly patient or a patient that's at the end of life, the hard, cold question I ask them is, would you rather receive a call that your loved one died from a natural process, like a clot or a stroke or a heart attack, or would you rather receive the call that your loved one has had an intracranial bleed and died from that?
Yeah.
So one is natural and one is iatrogenic, and that's the risks. Some of these medications cannot be reversed.
Right.
You don't have to monitor them. That's a good thing. No finger stick, but we can't monitor. We don't know where you're at.
So, in summary, the approach to deprescribing is to do an extensive medication review, which is going to take time, and also review the patient's goals of care. To make sure you know where your patient would like to be and what they would like to achieve on a daily basis.
Address the factors of harm with the good. Look at what their age, their frailty, their metabolism, other organ systems that might be involved in the distribution of those medications, the metabolism of those medications.
We want to make sure we not only engage the patient, but we're engaging the caregivers, families in the discussion. Sometimes as physicians, we need to speak to other physicians just to make sure that they're on the same page as us. We involve the whole medical team. We want to identify and decide together what medications should be reduced.
And just like with the list, when I ask patients to bring in a list of their meds, and I ask them to bring in a list of questions, when we go through their meds, I'll tell them, I see 2 on here I don't feel compelled for you to continue to take. Do you see any on here that you're willing to give up? And if those are the same medications, it's a win.
It's a win-win.
Yeah.
Right. And we always want to deprescribe in a stepwise approach. Do it slowly, tapering slowly, reduce one medication by 50%, and do it in a 2 to 4 week thing. Now, there are some medications you can just stop.
Because they're already on a low dose.
They're already on a low dose, but just make sure that you are discussing with your medical team. There are several barriers to deprescribing. Unfortunately, we are still living in this paternalistic society. As Dr. Bone and I discussed earlier, it was always a clinician-centered approach. So a lot of seniors are more respectful of the medical team, and they feel like this white coat means superiority. So we have to really demystify that.
We want patients to have that power to be able to communicate with us openly and honestly. And we need to be able to tell them, because we're supposed to be your expert medical guide.
Right.
We're not the ones that are going to tell you this is what you need to do. We want to tell you about the medication or about the risks, about the benefits, about the side effects, and then you have to tell us if it's worth it to you.
Right. Starting new medications for families and patients is viewed as doing something, right? A lot of times people have this view of, oh, I'm going to the physician's office. What are they going to give me?
I need a pill for that.
I need a pill for that. I need it to be helpful. I want it to be positive. That's what it's viewed as. So we have to really debunk that theory and start discussing what is going to be positive for you, your person, to live the best life.
The newer generation doesn't seem to have that respect for us, and
they have more respect for Google.
Yeah, and they check a lot with Dr. Google about what Dr. Google says about things, and that's good and that's bad as long as you will let me have some input,
Exactly.
And I want you to guide your care, but I can't have you dictate everything to me, because sometimes there are things that Dr. Google didn't tell you that maybe I know about.
Yeah, and a major barrier is fear-induced, as well as a lack of education, like Dr. Bone's saying with the Google. I mean, they may talk to somebody at a hair salon. I mean, it's amazing what patients come to us with, of where they've looked this information up and where they feel that it's valid.
Right. Finally, our parting thoughts with you are about deprescribing medications can decrease the risk of the burden, decrease your cost.
Yes. It helps decrease the risk of falls and cognitive impairment. It also creates a better compliance because we are creating a collaborative relationship. And if you know why you're taking this medication, the importance of it, you might actually take it.
Right.
Patients also, at the end of life, have a unique opportunity for deprescribing, and there's also challenges related to that. So it's really important as a healthcare provider to be looking at the whole patient, asking the deep questions to try to figure out the functional, the cognitive, the nutritional status of your patient, so we're able to determine, are they nearing the end of life, and do we need to not only have a deprescribing conversation, but also a goals of care conversation.
So yes, as you can tell, both Dr. Tartaglia and I do a lot of talking, but we also try to do a lot of listening to hear what the patient has to say. And so I appreciate the time you've given us today to listen to us. And if you've got something you want us to hear, please drop it in a comment below or send us an email.
Thank you for joining us today.
Bye now.
Bye-bye.